This week on the BackTable podcast.
Just speaking from a purely personal experience, I was giving a talk just a few months ago on some of the ASCO guidelines, and I had a slide that summarized the effect of yoga and all the different meta-analyses, systematic reviews, trials, and all of the different things that it works for. And I looked up at it and I kind of broke off from my standard talk spiel, and I said, my wife tells me I need to do more yoga, and looking at this, I realized I should do more yoga. So the more you learn about complementary medicine, you're going to help yourself. I would also say that one easy thing that is now becoming more clear in immunology and other research is if you were to have something as simple as a green smoothie that you make every day, both you as a surgeon and your patients and their family members are only going to benefit. There's nothing harmful that will happen. In fact, only good things will happen.
This is Aditya Bagrodia as your host this week, and I'm excited to introduce our guest today, Viraj Master, Professor of Urology at Emory University. Viraj, welcome to the show. How are you doing today?
Thanks so much, Aditya. A pleasure to be here. Great to be on the BackTable podcast. I feel like I'm a mini rock star in the making here by just getting on this podcast.
You're a full-blown rock star prior to any of this, Viraj. So thrilled to have you on, and I'm really excited. Of course, I've kind of followed your career and looked up to you my whole career through the SUO and various societies, incredible work and kidney, penile, and when we're kind of chatting at the AUA last year about interests and possible topics, you'd mentioned, somewhat as a surprise to me, that you were spearheading many of the integrative oncology efforts at Emory. Is that right?
That's true. I started the Integrative Oncology and Survivorship service line at our Comprehensive Cancer Center a few years ago now.
And I mean, that seemed like a no-brainer topic for a podcast. Something I would say I'm keenly interested in. Folks out here in California seem really, really into kind of a holistic approach to their cancer care. And maybe we'll just start out with some basics, some definition. Integrative oncology, what exactly are we talking about here?
So it's interesting to make sure that we get the definitions right. So integrative medicine, so not just integrative oncology, but integrative medicine is evidence-based use of complementary therapies in conjunction with conventional therapies. So integrative medicine or integrative oncology, for the purpose of our podcast, is not alternative. It is entirely complementary to conventional therapies that oncologists are wanting their patients to undergo.
Yeah. So trip down memory lane, when I was a medical student, we had a course called Complementary and Alternative Medicine, CAM. The complementary part sounds like it's more in line with what you're describing here. The alternative, maybe less so.
I think the alternative may have merit to it. However, as an allopathic physician working in a cancer center, I think that we cannot have our patients say, you don't need to have therapy for your muscle-invasive bladder cancer that consists of chemotherapy and likely surgery thereafter. Instead, do some infusion of some unknown compound. I just don't think that's the right approach. What I do think is the right approach is for us as conventional cancer physicians and urologists to lean into the fact that patients are thirsting for understanding what other things can they get exposed to, avail themselves of, what can they do to be a partner in improving their outcomes, whether it's symptomatology, which is really what I think the best evidence base is, or even changing things like their immune milieu. And for very rare circumstances, does it affect cancer-specific survival or disease-specific survival?
I was waiting to see what your kind of comment and where you fell on that was going to be. And by all means, we see it here, folks getting high dose vitamin, pick your vitamin, or going all ketogenic or all plant-based and, everything in between. And do you think that the lack of demonstrated benefit on oncologic outcomes is a lack of data or a lack of efficacy?
It's a great question. I think that the lack of data on oncologic outcomes is purely because we don't measure, and what we don't measure, we can't report on. We often don't measure these things because we don't even know what patients are taking. I will say that there are small trials that have been done, including in the phase 2 setting and the phase 3 setting, but a little bit smaller, really powered on symptomatology outcomes rather than cancer-specific outcomes. And I don't think that that's probably the first goal of ours. Probably the first goal is to see whether complementary therapies can reduce symptomatology during the active phase of treatment and decreasing the symptomatology burden in the survivorship phase of treatment, which is often underappreciated by physicians. Many times patients in the survivorship phase of their treatment are probably not seeing the physician, sometimes not even seeing members of the care team, but they have a myriad host of symptoms that are really not being attended to. So I would just say that this is our opportunity to do this. There's incredible associational data that the various complementary therapies or complementary modes of behavior that have effects in cancer. Let me give you a really easy example that's associational rather than necessarily causational, is the effect of exercise on completion of chemotherapy prescription. So there's a concept in medical oncology called RDI, relative dose intensity. So if your oncologist prescribes 100 units of something and you can get 100 units of that said systemic therapy, your outcome is likely to mirror the outcomes in many of the published studies. However, most patients don't get close to that recommended dose intensity. However, there's incredible studies published in high-impact journals, but completely ignored, that show that if you exercise during your systemic therapy time frame when you're getting systemic therapy prescribed, your relative dose intensity goes up, meaning you get all of the said systemic therapy you want. Associational, to be sure, but this is not one patient, 10 patients, 200 patients. This is thousands of patients. Probably the largest evidence base realistically is in breast cancer rather than in our urological cancers. For many of the urological cancers that you and I deal with, we face the fact that many participants don't want to enroll in trials, particularly trials of complementary therapy currently.
Yeah, I mean, in addition to that, and of course, we'll kind of dig into the symptoms that we hope to potentially abate and how to kind of do that. What I found is, and maybe just sharing a little bit of my evolution, initially used to be, hey, doc, what do you think about this? I don't know, makes me nervous, steer clear. Fast forward 3 or 4 years, hey, doc, what do you think about this? Well, it's probably not going to hurt you. Worst case, it doesn't help you. These days, a little bit more, again, it's intervention specific. The benefit I many times find is that it empowers patients to take some control as things are being done to them. They can actually do something, on top of the allopathic interventions that we have. Have you found that to be the case, or is that the case?
I think you're probably more evolved than many of your colleagues in how you're approaching this. Many physicians of every single subspecialty will often still steer clear from this, but there's a burgeoning interest. A group of us presented a course at the American College of Surgeons. I can't even believe it was accepted over there a couple of years ago. It turned out it was standing room only. The doors had to be closed because there were more surgeons highly interested in this. So I think there is a growing interest, but there's also a skepticism about really whether or not we should be spending any time talking to patients about this, or whether patients should do their own thing with whatever therapies they're going to use at home and not worry about it and only worry about the surgical procedure or the radiation procedure or the systemic therapy infusion the patient's going to get. That's a mistake, in my view. Americans are currently spending upwards of $80 billion in terms of out-of-pocket expenses on alternative and complementary therapies for a variety of disease conditions, not necessarily cancer, but those expenses are particularly magnified in the cancer space, where every single patient, their family member, wants to get some added benefit, one up on the cancer, and are searching for different things to try. If they don't have a feeling that their physician and their care team is interested in that, or worse still, is going to tell them to stop doing that, they're not going to tell us about that. So I applaud you for being receptive to patients talking to you about it. Probably the next step is to tell your patients and their families, tell me everything that you're thinking about taking, and I'll tell you if there's something that I think perhaps you shouldn't be taking. That's a little bit of a harder reach because it means that you have to know something about what medications or supplements are okay and what are not. In this regard, probably you and I as urologists, urologic oncologists, don't have as much of a knowledge base, but there's a whole specialty of naturopathic physicians who know a lot about what are the interactions between supplements, natural products, and conventional cancer therapies. And it'd be great for more physicians to lean upon, allopathic physicians to lean upon naturopathic medical doctors to try to help patients. At my own institution, we'll talk more about this. At our center, our Integrative Oncology service employs 2 naturopathic physicians who are instrumental, not only in telling patients what they may benefit from, but also in telling patients what things to stop doing during some of their systemic therapies. And it's very individualized to the actual systemic therapy the patient is getting. Some things work in contradistinction, some things work to enhance some of those systemic therapies.
Sure. Well, I appreciate that, Viraj. And, when I think about my integrative counseling, which absolutely is scratching the surface in the context of a 15 or 30-minute visit, the things that I at least try to touch base on in some kind of prescriptive fashion is diet, exercise, sleep hygiene, and supplements, and generally try to steer the patients and their caregivers towards resources that I think are more reliable and vetted. Of course, I think when you think about integrative options, we're talking about acupuncture, massage therapy, music therapy, spiritual therapy. What do you think kind of comprises like a moderately fleshed out integrative oncology program? And, what all domains are you going to kind of be able to hit there?
The top interests for patients are acupuncture and then supplement education. Now, I would say that it's not necessarily easy for every single care team and physician to access people who know a lot about supplements. Memorial Sloan Kettering has an amazing section of their website, their Integrative Oncology website, that goes over what are various supplements and what are some do's and don'ts or contraindications. So if the physician or the patient has time to do that, they can look that up. But I want to return to something that you just said, which I think is really key and a cornerstone. So complementary medicine is diet, it is exercise, it is mindfulness, it is music therapy, and yes, it can be some interventional thing like acupuncture. I would just say that luckily, as a community of urologists, we now can lean on the fact that the American Society for Clinical Oncology, ASCO, actually has put together a number of evidence-based white papers, which are out in press now, on common things that affect patients with cancer: pain, anxiety, depression, and sleep. 2 out of those guidelines are out. The next one is coming out shortly. And for anyone, whether you've read AUA, ACS, ASCO guidelines, these are rigorous data-supported pieces of material that have been produced. And so they're freely available. One were just to Google ASCO guidelines on pain, This is a joint guideline done by ASCO and the Society for Integrative Oncology that goes through, at a nutshell, what are the strength of recommendations for things like yoga therapy, music therapy, massage, acupuncture. Now, it's interesting. The highest level in terms of the strength of recommendation is moderate, and that's just because of the rigorous data processes ASCO goes through to try to give a strength of a recommendation, much like the AUA does. But I will just tell you, to cut to a nutshell, that things like yoga are incredibly impactful in a variety of different disease or symptomatology states, including pain, including fatigue, including anxiety, including depression, and including sleep. That's easy. You don't have to worry about it being a supplement. It's not. It's something that you can really just tell your patient, go and do this, or go and do this with your family members, or watch a YouTube video from the comfort of your home and just do some of the movements. You don't have to necessarily put yourself into a hot box at 95 degrees and do it. There's simple things that can be done. Things like mindfulness-based therapies that, again, are widely applicable for a variety of different disease conditions, whether, again, the active phase of therapy or in the survivorship phase of therapy. I have no affiliation with any of these companies that I'll describe, but there's apps that are free apps available for whichever platform one subscribes to. Insight Timer happens to be one that my patients seem to like. Again, I think it's a free app that's easily downloadable. The effect sizes for something like pain are usually in the 1 to 1.5 points on a visual analog score. So this is, if we were looking for a clinically palpable difference, it's around 2. Around 2 points on a VAS score is clinically palpable to a patient. So these don't necessarily by themselves get to that, but in conjunction, they absolutely get to it. I'm also going to describe that complementary therapy, again, is not trying to order a bunch of turmeric from some unknown seller on Amazon. Complementary therapy can be something like putting a cryotherapy pad or an ice bag on a surgical incision after surgery. I suppose that was my first entree into complementary medicine when I didn't know it was called complementary medicine. I was just thirsting to try to find out what I could do to help get my patients out of pain that wasn't usually utilizing a PCA. At that point, as a young faculty member, I wasn't having much luck with the use of epidurals at my own institution and a few others. And so I did a randomized trial of an ice pack versus no ice pack on patients with midline surgical incisions and found it actually made a difference, a clinically significant difference, would achieve that VAS point difference that I'm talking about. That's complementary. So I think if we draw a broad circle on what is really complementary, think of it as opening the box to all the things that patients and family members can do. Right now in our own operating room, I don't even have to say it. At the end of the case, my team, not the residents, fellows on the team, but the nurses and scrub techs, are getting a bag of ice and putting on the surgical incision. So it's that kind of work, I think, that tends to be more palatable to physicians and other care team members rather than just saying, let's try a supplement.
Yeah, I appreciate that. And, early on, you were talking about some of the kind of elements of a complementary approach and the impact on sleep, anxiety, depression. And it's a little bit hard to parse out what is kind of maybe cancer oriented and what is just maybe general well-being oriented. And is there even any reason to make a distinction?
Yeah, such a great question, and I'm really glad we're talking about this, because we're physicians. Why not try to increase the well-being that our patients have? If they have a cancer diagnosis, there's incredible worry for the patient and their families if they can learn tools, whether it's mindfulness practice, whether it's doing yoga together, whether it is doing other forms of exercise. That's all increasing well-being, and it happens to have a pleiotropic effect. And I will say that Some of these effects are now being understood by measuring immune correlates. And while I would say this data often is ex-United States and ex-Western Europe in terms of who reports it, but there are immune effects on things like acupuncture, for example, on CD8 positive T cells. So I would say that we all, as physicians, should feel great about telling patients to do things like exercise, like mindfulness, like yoga. We should feel that telling them to have a diet that is highly concentrated in fruits and vegetables, not necessarily telling them to give up something, but trying to put more fruits and vegetables in front of them or tell them to do that on their own dining tables, is a vote of confidence in complementary medicine. If we were to think about things that patients often do ask about, which is acupuncture harmful? The answer is no. Can you get acupuncture if you're anticoagulated? The answer is yes. Can you go to acupuncture if you have a low white blood cell count because you've been getting certain kinds of systemic therapy? Again, answer is yes. So this is acupuncture is what I would call a low harm, moderate efficacy service. We generally would say that you'll get a pretty rapid readout if acupuncture is working or not. It's 8 to 12 sessions. If it's working, great. You don't have to do more than 8 to 12 sessions. Symptoms come back, do it again. You can also do a maintenance program if you want. I think that's important as we think about healthcare costs as well as how to get patients to access specialists like acupuncturists who may be in high demand. At our own cancer center, we have 2 acupuncturists, and we deliver a novel group acupuncture model. And we see around 600 patients to 500 patients a month with this. So it just goes to show you that we started this program in January of 22. It was our first patient, first visit. And in a short 3-year time frame, we've completed more than 14,000 patient encounters with these therapies. So there's great thirst on the part of the patients. Once the skeptics in the cancer center start to realize their patients are benefiting, there's more referrals. So it's a virtuous cycle. But at the same time, if we need to make sure we have room for the next series of patients that are coming in. So generally we limit ourselves to 8 to 12 patient visits for acupuncture, and then they graduate on, often graduating to go to the community. If the patient can't bring themselves to the cancer center, maybe folks on the podcast might say, well, I've heard about acupressure. Can acupressure work? And the answer is absolutely. There are NIH-funded randomized controlled trials that look at the effect of acupuncture on dealing with patient anxiety as well as dealing with patient pain. These are randomized control trials, and acupressure absolutely can work. So I would say that these are things that it's fairly easy for a physician to recommend to the patient that doesn't involve the patient and the physician needing to spend a lot more time together. They can be referred on to patient resources on the Ask the website, for example, or others, or honestly, even YouTube to say, look up acupressure. So I think acupressure is something that for our patients who come from a distance or can't come or because of financial considerations can't, acupressure is still a viable thing to do.
Yeah, congratulations. What a resounding success. And not only just to do it, but to do it out in kind of unique models, group models, where you maybe get some sense of community on top of everything. Super cool. And I definitely find, in my practice, it seems like for most of the urologic cancers that if you make it 2 years without a recurrence, you're generally home free. And I guess in that survivorship land, I definitely find myself, if you kind of think of this like 2 triangles, moving my conversations more and more towards diet, exercise, lifestyle. You got a young man who's a testis cancer survivor, 2 years out, stage 1 on surveillance. He kind of knows the drill, right? Exam looks unremarkable, scans and markers are great. And that could be a 7-second visit. Or I kind of dig into it and touch on these things. And I think what you say about, trying to bring in the care team, because it's just a lot to cover in one session, can be a bit overwhelming. Let me ask you this. Take a patient, maybe newly diagnosed muscle-invasive bladder cancer, and you got a lot to kind of sort out. Neoadjuvant chemotherapy, chemo rads, meet the multi-D, diversions, etc. Can you walk us through the kind of practical implementation of a integrative approach across like the patient journey from diagnosis to survivorship?
Sure, that's a great question and a great example, probably one of our more high acuity patients that we deal with. First off, there's a tremendous amount of anxiety that the patient and their family has. Change in body image, cancer control, sometimes continence issues are all coming up. So there's tremendous anxiety that's going to happen. Things like music therapy, things like aromatherapy, particularly the largest effect size with lavender oil in the evenings, can, again, our data supported things in decreasing anxiety, promoting sleep. Meditation or mindfulness would be encouraged. I would just say, so that's something that's mental. Then the patient might go on to get neoadjuvant therapy, likely would. And that neoadjuvant therapy produces a host of side effects that we often maybe are not seeing the patient exactly during that time. We probably see them right before the cystectomy occurs. But they have tremendous nausea and vomiting. And this is where something like PC6 manipulation, so that's it's an acupoint 3 finger breadths above the wrist crease in between the two flexor tendons, can be very effective. I don't mean mildly effective, I mean very effective. There's three Cochrane collaborative reviews that look at the effect of PC6 on nausea and vomiting. So I would say that's something that we can tell patients to take it to the bank, whether it is acupressure they themselves are doing or whether they wear something like a C-band, which you can get in any grocery store or pharmacy store. It doesn't require a prescription. That's a little wristband that has a small bead on it, and you put it in between those two tendons, 3 finger breadths above the wrist crease, and it just stays there. That could be very, very helpful. That same principle, by the way, will help when they do come to the operating room for their cystectomy. Those patients should be listening to music if they can in the pre-op holding area. There are randomized control trials that look specifically at the effect of reduction in anxiety. I tell all my patients to bring in their favorite music in the operating room, depending on who the anesthesiology care team partner is. Sometimes they're okay with patients still having music in their ear, sometimes not, and that's okay. But I would encourage that. Post-operatively, our patients with abdominal surgery, whether it's minimally invasive or maximally invasive, will still have post-operative nausea, vomiting. In some studies, up to 50% of patients can experience post-op nausea and vomiting, and that same kind of thing that they had started at the beginning, thinking about management of the nausea vomiting, can be continued through their hospital journey with PC6 stimulation. PC6, by the way, stands for pericardium 6. Don't ask me exactly why it's called pericardium 6, but I've told you a couple of times on where it is. Again, 3 finger breadths above the wrist crease in between the two flexor tendons. So that can be done. Put ice on the patients. Again, almost any size incision is painful to the patient. So whether it's being done in an MIS fashion or in an open fashion, I would get the ice pack on. In our own published work, and I would just say that there's meta-analyses that have looked at literally thousands of patients and the effect of cryotherapy, 51 different randomized controlled trials. There is no patient's untoward patient safety issues. You're not going to cause a wound infection by putting an ice pack on. Patients aren't going to develop frostbite by having an ice pack on themselves. You're not going to affect a stoma if there's a stoma on the patient. So I would say that's something that you can do. And again, while we're discussing the arc of the cystectomy patients, that's not the only patient population that these things could help with. What about other complementary therapies that we often ignore? Again, complementary therapies don't have to be really fancy things, Aditya. Ileus happens to a number of our patients, whether we wanted to or not, sometimes to our consternation. Things like drinking hot liquids, chewing on gum, hard candies. Again, data-supported, complementary views that are patient and family facing, things that they can do while they're in their bed to help with things like ileus. When the patient is discharged, again, things that bring the patients back to the hospital are often things like dehydration that often starts with this dreaded nausea, vomiting, dehydration cycle that
Failure
results
to
in that.
thrive.
Right. So these are things that, again, we can help with the nausea, which I just mentioned. Things that are data supported are how the essential oils can reduce the feelings of nausea that the patient has, whether they're applied on the wrists, whether they're just in a diffuser. It doesn't have to be expensive, and nor does it have to be something that the patient feels that has to be done exactly in a certain way. I want to decrease the amount of anxiety that physicians and patients, their families have about how to use complementary therapies. This is not, a precision robot that's, going for millimeter 1 versus millimeter 2. These should be things that patients and their families feel empowered by us to do to see whether they can feel better. One word on supplements, Aditya. I think it's important. We haven't really talked that much about supplements, and kind of purposefully, because I worry a little bit about this, that the internet abounds in various things that patients can take. Patients are often printing out things and asking me, what about this particular product? It's going to cure my cancer, or it's going to stop my cancer from coming back. The supplement market is highly unregulated currently. There's very few vendors that will necessarily be able to provide excellent quality control, limit batch-to-batch variations. So if one is really interested in their patients availing themselves of that, I would say partner with a naturopathic physician. Sometimes, though, they're available in communities. If you look, we often, as allopathic physicians, don't know to look there, but I would say they can be very effective. But if there is financial toxicity that patients are experiencing, and so many of our patients have under-recognized financial toxicity, then the common sense things that we've been talking about, the dietary modifications, exercise modifications, are all perfectly reasonable. I would also, to continue with the story of our cystectomy patient, say a word on immunonutrition. Immunonutrition is a kind of a hot topic. I would say this is a drink that one can ingest that contains various substances in it that changes the immune milieu. Oftentimes, these are protein-rich supplements and increases wound healing. There are literally hundreds now of trials that have looked at this. Probably the best data comes from the colorectal cancer population, looking at wound infections, fistulae formation, dehiscences. And in terms of immunonutrition, I would say immunonutrition is something that is achieving a lot of popularity, perhaps pushed along by various commercial vendors. It is a combination of different amino acids, usually arginine, glutamine, and valine as the amino acids, omega-3s, and then some amount of protein that decrease really easy to measure complications like infections, dehiscence, fistulae formation, and again, literally hundreds of studies have reported on the effect of immunonutrition. Now, I myself am interested in patients and their families having some ownership and control of this. So our team at Emory, who's interested in reversing the frailty phenotype, has come up with what I call an immunonutrition shake. I'm not saying that all of you need to do it. I've got no vested interest in this, but as a resource for patients, families, and physicians, if you navigate your way to frailpatient.com, you'll find a tab that says immunonutrition, and you can see a sensible cocktail that one can make using common ingredients: peanuts, walnuts, sunflower seeds, pumpkin seeds, to actually create in a very natural and holistic fashion a shake, and all the ingredient constituents are all listed over there. That's really cost effective. Sometimes if you buy it from some of the large pharma corporations, I won't name their names, these are $10 a shake. They're actually far too sugary anyway for many of our diabetic patients. But if patients and families can say, here's a recipe that I can follow, I can modify it to my and my family's taste and needs. Immunonutrition is something that is helpful. The polarization of Th1 to Th2 macrophages has been studied extensively in this context. And again, those constituents that I mentioned earlier are active in changing this immune contexture. So that's one thing the patient can do before treatment, because you're training for surgery. You're actually training to get chemotherapy too, so they can do it at every point in their journey, and then in the immediate perioperative part too.
I love it. I love it. I mean, not only does it sound like it might be a immunonutrition, it sounds delicious.
It is, yeah. I sometimes make it and give it to our different team members too. We actually experimented with it ourselves before we dared to put it up on the webpage.
So, two things that I'm guessing are not California specific that come up. You can probably read my mind on this one. CBD, cannabis would be the first one. If you have any opinions there, or if there's any data, anecdotally, patients tell me about. Well, I'll just share this. I had a young man literally last week and asked about. He was newly diagnosed testicular cancer, and he asked me about cannabis use, and seemed like a very level-headed guy. Explained to me that he uses cannabis to help with sleep hygiene. He literally said sleep hygiene. And I kind of panicked because I don't really know the data. There's some association data with testis cancer specifically, neither here nor there. But where I landed was, I think it'd be probably preferable to move away from daily use and try to come up with some other mechanisms to help out with sleep hygiene. But admittedly, that wasn't like based on anything more than like a gestalt. But it comes up all the time that this helps me with pain, this helps me with anxiety, this helps me with nausea. So you mind educating us a bit on that one, Viraj, not to put you on the spot?
Yeah, that's talk about a tough question to answer. One, I would say that every person listening to the podcast should be aware of a resource available at the NIH NCI. So this is the IACT, Integrative Alternative and Complementary Therapies section over there. So if you Googled NIH NCI IACT, you'd get to this page. And there, true world experts come together and look at the latest data. We do this 4 times a year of different modalities. Cannabis, cannabinoids their derivatives are one of those categories. So are mushrooms, for example. So I won't necessarily tell you the exact do's and don'ts. I think it remains for patients and their families or their physicians to see, well, what is the latest data? And this is a changing field. The science is not always great quality science, but again, is at these meetings where a bunch of panel members come together and really try to dissect out what is a good study and what can't be. So what you see on that webpage probably represents the latest in 2025 understanding of what we would support and what we feel that we can't support, or what there's not enough data to support a contention like that.
Yeah. No, I appreciate that. And, just a little bit more about the about this particular guy. He was like, all right, I'm just still kind of dealing with a lot. I don't want to really rock the boat. And I was like, all right, I get that. I was like, if I had to land somewhere, I'd probably advise against smoking. That seems like it's got some more kind of carcinogenic features than ingestibles. And then he shared with me that, from the time of ingesting to feeling an effect, and the severity or intensity of the effect didn't kind of really work well. And at this point, I was like totally tied up in knots and worried about saying something I wish I hadn't and sticking my foot in my mouth. So I absolutely appreciate that it's complicated. This sounds like a great resource. And and I'll definitely check it out. Another one that maybe it's a West Coast thing, maybe it's my background as an Indian American, Ayurveda, things along those lines, data, opinions.
Yeah, I think, well, one, Ayurveda is one of the most ancient of all medical scientists. Every single culture has had a tradition. Tai Chi, supplements, and acupuncture are part of traditional Chinese medicine. Again, something that dates back thousands of years, much like Ayurveda does. It's actually one of the Vedic sciences, as you well know. I think that our evidence base is currently smaller to understand various Ayurvedic modifications that we could tell the patient just to take carte blanche. Partially, one really requires a assessment of the patient. So Ayurveda does presume that you can diagnose what a patient might be deficient in, has an excess of, and I'll just say the traditional Chinese medicine also does the same thing. So all of these ancient medical knowledge bases are all trying to personalize medicine. At the 7,000 years ago, they were doing personalized medicine. So an Ayurvedic compound that might be given to you, or that they might be very different than the Ayurvedic compound that would be prescribed to me by a good Ayurvedic practitioner. So I would say that if you or your patients feel that they have someone who's trustworthy that really can individualize the therapy to them, super, go for it. But in the absence of that, have a caution before you are taking various Ayurvedic supplements or even traditional Chinese medicine supplements, Unani supplements. You have it across the world. There are different things, but again, they're all predicated on the personalized assessment of the patient. And that's one reason why I'm a big fan of things that are fairly pleiotropic. Yoga does not involve a personalized assessment of the patient. It involves doing poses that are approachable to the patient, and when you can't do a certain pose, you can't do a certain pose. Right? So no necessarily significant harm is going to come to the patient, where I do worry sometimes about the overuse of supplements, which again, as a culture, we're spending a lot of money on. I'll just say, in my own family, I see various bottles of various things that come from Amazon, mostly from my children, and I think, do we really know that this is okay? So I will just say that I like the idea of exercise. I like the idea of nutrition. I think acupuncture, again, is a intervention that is not going to harm you, that will get a pretty quick readout on.
Yeah, I love it, Viraj. And just kind of hearing the various different interventions, the pressure, the music, the diet, the aromatherapy. It just seems like such a less foreign, intimidating, sterile experience where a lot of scary stuff is being done to somebody without any input or control, to a more involved experience where you feel like you might be able to impact the outcomes, symptoms, or potentially beyond that. At the very least, you're probably getting something from a general health perspective. That's always a good thing. And then maybe, a silver lining opportunity to establish some good life habits as you kind of move through your journey of active treatment to survivorship. Because as we all know, many times this is a big recalibration for people when they get hit with the cancer diagnosis. So I love it. And I mean, I can just like envision in my mind somebody just feeling like a lot more comfortable and relaxed. And even things like you think about cortisol levels and stress levels and what that could do to any number of things, not live, die, recur, don't recur, but better than without, as a very low bar. Does that sound about right?
Absolutely. I think that this is an extraordinary moment of patients and in their family's life. And it's an extraordinarily teachable moment on our part as cancer physicians. So here's where, to your point exactly, we can help the patient and their family get empowered with some sensible modifications that are going to improve general life for them. And specifically, it'll make their time in the hospital care setting, frankly, easier.
Well, that's the goal, right? I mean, to get those outcomes and along the journey and beyond, improve quality of life and happiness and those things that are so much harder to touch upon, harder to quantify, and frankly, I think harder to implement at a lot of different levels. And, I could pick your brain for another like 2 hours on everything kind of related, both directly and tangentially to this topic. But I want to be respectful, Viraj. So, congratulations and thanks for what you're doing. I think the interest both on patient and providers sides makes like total sense, and it's timely as we truly think about patient-centered care. And maybe I'd ask you, as we're kind of winding down here, any parting thoughts for the listenership or even for any patients that might be listening?
My reading on this, and I've read pretty deeply on it, and I study it. I write grants on this. I collaborate with people nationally and internationally about this. If you do have interests, please consider joining the Society for Integrative Oncology. I happen to chair the research committee, and we do great work in this regard. Do advocate for sessions at your local society meetings, regional or national, to incorporate this, because you will benefit, your patients will benefit. The things that you tell your patients, if you start to incorporate them, and just speaking from a purely personal experience, I was giving a talk just a few months ago on some of the ASCO guidelines, and I had a slide that summarized the effect of yoga and all the different meta-analyses, systematic reviews, trials, and all of the different things that it works for. And I looked up at it and I kind of broke off from my standard talk spiel, and I said, my wife tells me I need to do more yoga, and looking at this, I realized I should do more yoga. So the more you learn about complementary medicine, you're going to help yourself. I would also say that one easy thing that is now becoming more clear in immunology and other research is, if you were to have something as simple as a green smoothie that you make every day, both you as a surgeon and your patients and their family members are only going to benefit. There's nothing harmful that will happen. In fact, only good things will happen. So probably those are two takeaways for the listeners over here, and probably personal takeaways too.
All right, Viraj. Well, thank you. There's definitely going to have to be a part 2 to kind of make sure I get a chance to run through the rest of it. Appreciate your time, your expertise. Keep doing what you're doing.
Delighted. Great to see you, Aditya.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for listening. See you next time.